Picture this. Two people walk into a clinic on the same afternoon. Both are 72 years old. Both have a blood pressure reading of 118/72, a number most people would call perfect. One of them feels fine. The other is gripping the exam table because the room won't stop spinning, and by the time they stand up to leave, they're seeing stars. Same number, same age, completely different bodies, completely different risks. And that right there is the piece of the blood pressure conversation that almost nobody explains properly. If you're 60 or older, or you're caring for someone who is, you've probably been told a version of the same story your entire adult life. Get your blood pressure down, lower is better, don't stop until you hit the target on the chart. And for a lot of people, that advice is genuinely good. But for a growing number of older adults, chasing that number too aggressively isn't just unhelpful, it's dangerous. It can cause falls, it can cause fainting spells. In the worst cases, it can cause a fatal brain bleed from a fall that never needed to happen. So today, we're going to unpack this properly. I'm going to walk you through what the two biggest studies on blood pressure in older adults actually found, not just the headline, but the fine print that most explanations conveniently leave out. Then I'm going to give you the exact age-based framework that's used to set safe, individualized blood pressure targets so that by the end of this video, you'll know roughly where your own number should sit. And just as importantly, what warning signs mean your target has been pushed too low. Stick around because the second half of this video covers the specific red flag symptoms that tell you your blood pressure has dropped past the point of being helpful. And that part alone could save you or someone you love from a bad fall. Let's start by clearing up the biggest myth in this entire conversation. There is no universal blood pressure number. Most people assume blood pressure works like a thermostat. There's a number that's normal, a number that's high, and everyone is supposed to aim for the same target regardless of who they are. That belief is so deeply baked into how we talk about health that almost nobody questions it. Here's the problem. The categories you see, normal, elevated, stage 1 hypertension, stage 2 hypertension, those are just labels. They tell you which bucket your numbers fall into. What they don't tell you is whether that number is actually safe for your specific body. They don't tell you whether your brain is getting adequate blood flow. They don't tell you whether your kidneys can tolerate the medications required to hit that number. And they definitely don't tell you whether pushing your blood pressure lower is going to protect you or put you at greater risk of a fall. That depends on a long list of individual factors. How stiff your arteries have become with age, whether you're already experiencing dizziness or brain fog or unexplained fatigue, your personal fall risk, how many medications you're currently juggling, how well your kidneys are functioning, your cognitive health, your activity level, and, this is a big one, how your particular body actually responds to treatment. Two people can be handed the exact same pill at the exact same dose and have wildly different reactions. This is exactly why one person can sit at 118/72 and feel like they're in the best shape of their life, while someone else at that identical number is dizzy, foggy, exhausted, and one bad moment away from a fall. The number on the cuff is only half the story. The other half is how your body is actually experiencing that number, day to day, moment to moment. So the real question isn't, what's the ideal blood pressure? The real question is, what's the ideal blood pressure for someone with my specific health picture? And to answer that, we need to look at where these guidelines actually came from, because once you see the fine print, the whole picture changes. What the landmark trials actually found, and what they left out. There are two major studies that shaped how doctors think about blood pressure in older adults, and if you only hear the summary version, you'll walk away with the wrong idea entirely. The first is a large American trial from 2015 that followed over 9,000 adults, all 50 and older with an average age right around 68. Researchers split participants into two groups. One group aimed for an intensive target, systolic blood pressure under 120. The other aimed for a more standard target, under 140. The headline result sounds simple. The group that pushed their blood pressure down to under 120 had fewer heart attacks, fewer strokes, and fewer cardiovascular deaths. On the surface, that seems to settle the debate. Lower is better, full stop. Everyone should aim for under 120, except that's not the full story. That same intensive group also experienced significantly more dizziness, more fainting episodes, more electrolyte imbalances, more kidney complications, and more falls. In other words, yes, fewer people were having heart attacks, but a meaningful number of them were now living with blood pressure so low that they were losing their balance, blacking out, and hitting the ground. And a fall in your 70s or 80s isn't a minor inconvenience. A fall can mean a hip fracture. A fall can mean a head injury. A fall can mean a hospital stay that triggers a cascade of complications that has nothing to do with the heart at all. And here's the part that almost never makes it into the conversation. That trial excluded huge portions of the real-world population. Nobody with diabetes was allowed in, nobody with a prior stroke, nobody with dementia, nobody with advanced kidney disease, nobody dealing with significant frailty. So what this trial actually proved was that a target under 120 can benefit strong, resilient, highly active older adults with relatively few other health complications. It did not prove that this target is safe or appropriate for the average older adult walking into a clinic today, the one managing 3 chronic conditions, taking half a dozen medications, and already feeling a little unsteady on their feet. The second major study came out of China in 2021, and it followed a similar design with over 8,500 participants between the ages of 60 and 80. Same setup, an intensive group targeting under 120, a standard group targeting under 140. And the results echoed the first trial almost exactly. Fewer cardiovascular events in the lower blood pressure group, but again, more dizziness, more kidney strain, more fainting. So when you put these two studies together, the takeaway isn't everyone over 60 should aim for under 120. The real takeaway is far more nuanced and honestly far more useful. An aggressive target can be genuinely protective for the right person and genuinely risky for the wrong one. The trials weren't wrong. The way people summarize the trials is what's misleading. So what does this actually mean for you? Let's translate the research into something practical. If you're over 60, you're walking regularly, you're highly independent, your thinking is sharp, your kidneys are in good shape, and you're not juggling a long list of medications, you may genuinely benefit from a tighter target, something closer to that under 120 systolic range the trials tested. Your body has the reserve to handle it, and the cardiovascular protection may well be worth it. But if you're over 60 and you're managing multiple health conditions, taking 4 or more medications, your kidney function isn't what it used to be, you already get lightheaded from time to time, and you've had a stumble or a near fall recently, chasing that same under 120 number isn't cautious, it's aggressive, and it can actually work against you. The goal of blood pressure management was never supposed to be hitting a number on a chart. It was always supposed to be protecting your body, your independence, and your quality of life. Sometimes those two things point in the same direction. Sometimes they don't. This is where a lot of people get stuck, though, because how do you actually know which category you fall into? Your body is constantly giving you feedback. You just have to know what signals to pay attention to. The warning signs. Your blood pressure is too low. There's a specific set of red flags that indicate your current target has been pushed past the point of being helpful. And if you notice any one of these, it's worth having a conversation about backing things off rather than pushing further. Severe lightheadedness when you stand up, the kind where the room tilts and you have to grab onto something, is one of the clearest signs. So is dizziness that consistently shows up in the morning before you've even had a chance to fully get moving. Brain fog that seems to come and go without explanation is another one people tend to dismiss as just getting older, when in reality it can be a direct sign that your brain isn't getting quite enough blood flow. Persistent fatigue that doesn't improve with rest, a general sense of unsteadiness on your feet, muscle cramps or signs of an electrolyte imbalance, and a systolic reading that regularly dips below 100 are all part of the same pattern. Any one of these on its own might not mean much, but if you're noticing several of them together, especially after a medication change, that's your body sending a clear message. This target is too low for me right now as I am, and that message matters just as much as any number on a chart. Low blood pressure might sound like a universally good thing, but not when it comes at the cost of your balance, your clarity, and your safety. The framework, finding your actual target. So let's get to the number you actually came here for. Based on everything we've just walked through, here's a practical, age-adjusted framework that fits the vast majority of older adults. If you're between 60 and 79, active, independent, and not managing significant chronic conditions, a reasonable target sits under 130 over 80. Your body likely has the resilience to handle that range comfortably, and the cardiovascular benefits are well worth pursuing. If you're in that same 60 to 79 age range, but you're dealing with dizziness, some frailty, multiple medical conditions, or a longer medication list, a more appropriate target is under 140 over 90. This gives you meaningful protection against cardiovascular events without pushing your body into the danger zone of falls and fainting. And if you're 80 or older, the target generally shifts to somewhere between 130 and 150 systolic, with the exact number, depending heavily on your individual symptoms and overall health picture. If you happen to tolerate 120 or lower without any side effects at all, no dizziness, no fatigue, no fogginess, that lower number might offer some extra protection. But that's only true if your body is actually handling it well. The moment side effects show up, the equation changes. Notice what this framework is actually built around. It's not built around a single fixed number that applies to everyone equally. It's built around how you're functioning, your independence, your symptoms, your overall resilience. That's the entire point. Two people can walk in with identical blood pressure readings and walk out with two completely different treatment plans, because the number was never the whole story. The person behind the number always was. Why this matters more than most people realize. Here's something worth sitting with for a second. A lot of well-meaning advice out there treats blood pressure like a scoreboard and get the number as low as possible, as fast as possible, and consider it a win. But medicine, especially as we get older, is rarely that simple. Your body at 70 is not the same machine it was at 40. Your arteries have changed. Your kidneys process medications differently. Your balance and reflexes aren't what they used to be. Treating. G an 80-year-old's blood pressure with the exact same aggressiveness you'd use on a 45-year-old isn't just outdated thinking. It can genuinely put someone at risk. This is also why it's so important to have an honest, ongoing conversation with whoever manages your care, rather than simply accepting a number and never revisiting it. Your ideal target today might not be your ideal target in 2 years. If you become more active, lose weight, or improve other areas of your health, your body might handle a lower target beautifully. On the flip side, if a new condition develops or a fall risk increases, that target might need to move in the other direction. Blood pressure management isn't a one-time decision. It's something that should be revisited as your life and your health evolve. And honestly, this is where a lot of people go wrong. Not because they're not trying, but because they're chasing a single number they read somewhere online or heard from a friend, without ever asking whether that number actually fits them. Numbers without context aren't guidance. They're guesswork. Making sure you're even getting accurate readings. Here's something that deserves more attention than it usually gets. Even if you land on the perfect personalized target, from there, a good approach means starting with a target that fits your current health picture rather than a generic guideline, and then paying close attention to how your body responds over the following weeks. If you're tolerating it well, no dizziness, no unusual fatigue, steady energy, that's a strong sign. The target is appropriate. If warning signs start showing up, that's valuable information too, not a failure, just feedback that the target needs to be adjusted. This back and forth process, checking in, adjusting, reassessing, is what real personalized care looks like. It's slower and less satisfying than simply being handed a single number and told to hit it no matter what. But it's also far safer, and over time it tends to produce better outcomes precisely because it's built around your actual body instead of an average drawn from a study population that may not resemble you at all. Bringing it all together. Let's zoom back out for a moment because it's easy to get lost in numbers and forget the bigger picture. Blood pressure management. For older adults isn't about blindly following a chart. It's not about hitting the lowest possible number just because a headline told you lower is always better. And it's definitely not about ignoring how your body actually feels in favor of what a device says. It's about understanding that you are not a category. You're a person with a specific history, a specific set of conditions, a specific umptone level of activity, and a body that responds to treatment in its own particular way. The research gives us a starting point. Real, valuable data from thousands of participants that helps guide these decisions. But research sets ranges, not individual verdicts. Your idea L number lives somewhere inside those ranges, shaped by everything that makes your health picture uniquely yours. If you're active, resilient, and largely free of complicating conditions, a tighter target can genuinely add years of protection to your heart and your brain. If your body is telling you, through dizziness, through fatigue, through unsteadiness, that a lower number R isn't sitting well with you, that feedback deserves just as much respect as any guideline. The goal was never a perfect number on a screen. The goal is a body that functions well, feels steady, and stays independent for as long as possible. So take what you've learned here and actually use it. Think honestly about which category fits you right now. Not who you were 10 years ago, but who you are today. Pay attention to how your body responds, not just to what the cuff says. And if something about your current target doesn't feel right, that's worth bringing up rather than brushing aside. Managing blood pressure well later in life isn't about fear, and it isn't about chasing perfection. It's about working with your body instead of against it, understanding that the healthiest number isn't the lowest one possible. It's the one your particular body can actually thrive on. If this gave you a clearer picture of where your own numbers might realistically sit, the next step worth taking is making sure the readings you're basing all of this on are actually reliable. There's a whole set of small, common mistakes people make when checking their blood pressure at home that anyone can throw the numbers off without anyone realizing it. And getting those right is just as important as knowing your target in the first place. Pressure readings that are quietly off by 10, 15, even 20 points, simply because of small avoidable mistakes in how the reading was taken. Things like sitting with your feet uncrossed and flat on the floor, having your arm properly supported at heart level, resting quietly make a measurable difference. Get any of these wrong consistently, and you could end up chasing a target based on numbers that were never accurate to begin with, either overtreating a body that didn't need it, or worse, undertreating one that did. The medication trap. Nobody warns you about. There's another layer to this conversation that deserves its own moment because it trips up more people than you'd expect. As we get older, it's incredibly common to end up on more than one blood pressure medication, sometimes 2, sometimes 3, occasionally more, especially if numbers crept up gradually over several years, and each visit added another prescription rather than reevaluating the whole picture. That's already dealing with reduced kidney function or age-related changes in how drugs are processed. The combined effect can be much stronger than anyone anticipated. Your official numbers might say your blood pressure is well controlled, but what's actually that the medications are failing. It's that the combination has quietly overshot the target. This is exactly why it's worth periodically reviewing every medication with whoever manages your care, not just the newest one that got added, but the entire list together. Sometimes the safest, most effective change isn't adding something new. It's simplifying what's already there. Common myths that keep people from getting this right. Let's clear up a few misconceptions that tend to circulate because none of it matters if the readings you're basing decisions on aren't accurate in the first place. So many people are making treatment decisions off of home blood